So my name's Tim Shaw. I'm from the University of Sydney, and it's a great pleasure for me to introduce this morning's program as a member of the ISQua Education Committee and also chair of the Sydney Catalyst Implementation Working Party. Just while people are joining us, I might just run through some housekeeping messages. So everybody, we're expecting around 60 or so people this morning, so everybody will be muted automatically, so you won't be able to talk. It's just too difficult to handle. We very much encourage you to participate though within the webinar by posting questions, and you'll see, if you haven't used WebEx before, you'll see down in the bottom right hand corner there's a little chat box screen. So if you type those messages in, I'll be putting those to John and myself after John's given his presentation. There's also no teleconference facility, so your sound will be coming through your computer. Dr. John Wakefield will be giving a presentation. I'll introduce John shortly. John's going to give about a 10 to 15 minute talk, following which we'd certainly like you to post questions. I've got a number of questions I want to chat through with John as well. Obviously that discussion is what we really want to do out of this webinar, not too much of a didactic presentation. So we're looking forward to you participating and bring some of your own thoughts from your own clinical areas and environments. So before we begin, I'd just like to introduce the three organisations that are sponsoring this webinar. So this program is actually being run out of the ISQua as part of the ISQua webinar series. So some of you may be familiar with ISQua. ISQua is the International Society for Quality in Healthcare. It's based in Dublin. I sit on the education of ISQua, and ISQua is increasingly over the last few years really getting engaged in education of health workforce. And in fact, ISQua has just launched a fellowship program where we have over 50 international fellows now studying to become ISQua fellows. And I certainly encourage you to look at that program, and participating in the webinars is one of the activities that fellows undertake as well. The Clinical Excellence Commission, headed by Cliff Hughes, is also sponsoring in this program. So many of you are familiar with CEC, which has a central role in the responsibility for quality and safety in the New South Wales healthcare system. It was established in 2004 and really is focused on promoting and supporting improved clinical care and safety across New South Wales. The third group that's involved in this webinar is Sydney Catalyst, which is the Translational Cancer Research Centre that's funded by the Cancer Institute New South Wales. This is a new initiative. It's about a year and a half, 2 years old now, where it's an organisation that spreads across some of the large teaching hospitals in New South Wales. And as I mentioned before, I'm chairing the Evidence into Practice Implementation Working Party, so we have a very special interest in changing behaviour. I'm particularly happy that we're bringing these different groups together in this webinar, because when John and I were talking before, one of, I guess, some of the frustrations we feel is that there's different worlds of quality and clinical practice and clinical research, and they're often not coming together. So I think groups like Sydney Catalyst have the opportunity to span that divide so that we can use quality improvement and methodologies combined with implementation science and so on that occurs more in the academic domain. But we may talk a little bit more about that after the webinar. So without further ado, I'd like to introduce Dr. John Wakefield. John and I have worked on a couple of programs before. John is a UK medical graduate. He's worked in private and public health in Queensland since 1989. So he's got over 20 years experience crossing that divide between clinical and management roles in rural, regional and tertiary public sectors. John really has a broad understanding of the challenges of delivering healthcare services in large decentralised states.
I guess my objective today, and it's my objective in many of the sessions that I do, is really to mess with your heads a little. And if I get you to go away from today's presentation thinking about how you design and implement change in the organisation and move beyond knowledge to understanding why people behave in certain ways and how to change that, I'll have been successful and I particularly want to challenge some myths. So if you find yourself feeling uncomfortable about some of the things I'm going to say today, then I think I've been successful. I want to start off with an example, and it's a fairly simple example. It's one that's received a lot of press recently, and it's hand hygiene. Using our traditional sort of model of thinking about how we as practitioners practice decisions that we make as being pretty rational and evidence-based, this is a great example which illustrates that's actually not the case. So if you think about hand hygiene, the assumption in a normal pedagogical model is that, we're rational scientific beings. We just have to have the training in why hand hygiene is important and how to do it. And Bob's your uncle, there it is, everyone will do it. Well, we actually know clearly that's not the case. In fact, Michael Whitby, a colleague of mine, and Mary Louise McClaws have really explored this in some detail and essentially found the reasons why people wash their hands and why clinicians wash their hands. And there's two components to that they've discovered. On the one hand, there's what they call the elective component. Now, you don't have to teach people to do that. That is when people's hands are dirty or soiled with human body fluids and so on, they will wash their hands. That is a normal behaviour which we don't have to train people to. The other component is what they call inherent hand hygiene, which is actually a function of, believe it or not, what you learn in the first 2 years of life, and modelled by usually by your mother. And that's when your hands are not soiled, but that's the sort of wash your hands before and after going to the toilet, washing your hands before you eat, etc. Now, if you don't get that behaviour instilled in you in your first couple of years of life, you're very unlikely to have to be able to crack and change that in later life, and that is not a knowledge issue. So that's just so I think, again, our usual approach, what I want to do today is get you to challenge your thinking about why we do what we do, because that actually has a profound implications for how we design our interventions around changing practice. Sorry, let me get this to work. So let's explore a few common myths about what drives clinician behaviour. So we are rational human beings. We are scientists. We pride ourselves on moving with the evidence. So here's myth number one. This applies to us. I'm a scientist. My practice is based on the published evidence. Well, actually, that is far from the truth when it comes to what's out there. You'll know there's been good work done by Jeffrey Braithwaite and colleagues, which is that Runciman study shown there, which showed that roughly half of treatment of care that's provided is not in accordance with undisputed level 1 evidence. And there's a range of other studies from around the world about that. Other perhaps less methodologically sound data, but which suggests that it takes around 20 years to get established evidence into practice. And my own research, and it's backed up by research elsewhere, is that clinical practice is no different to that hand hygiene example that I gave you. It's largely driven by personal experience and beliefs rather than published evidence. Myth number two, the best way to change clinician behaviour is through education. Now, I'm not suggesting here that education is not a component of a behavioural change plan, but the evidence is quite clear that education alone has actually very little effect at all in changing clinician behaviour. And that's because largely the barrier is not one of knowledge deficit. Now, education, obviously, knowledge of how to do a particular thing is essential if you want people to do it. But in fact, that is not the predominant factor that you have to consider when you're trying to change behaviour. And I'll explain that further in a moment. Myth number 3, my practice is not affected by drug reps or advertising campaigns. Well, for those of you that are in Australia, you may have seen the latest, I think it's Catalyst program around cholesterol management, which dealt with this last night, in fact. But the very reason that drug companies spend a lot of money in these areas is because they do work. And it is wrapped up in that social marketing element and the relationship that you form with that drug rep who is particularly selected to be a person that actually can create those relationships. That relationship drives prescribing behaviour. In a similar way, if you go to the US, you'll see a lot of media and advertisements without using drug names that really seek to tap into the community's desires, and that community desire, when transplanted onto clinicians, again, does change clinician behaviour and prescribing practice. They do it because it works. Myth number 4, my practice is not affected by regulation or payment systems. Again, whether we like it or not, and it's not always in a good way, our behaviour is changed by such regulatory or structural change. So, for example, interestingly, when public reporting of individual performance, practitioner performance, doesn't change patient behaviour, it does change practitioner behaviour. Examples of that include complication rates in cardiac surgery in the US, for example, where doctors started to do less high-risk patients, and that can have positive and negative implications. Payment mechanisms absolutely work to change doctors' behaviour, and again, not always in a good way. Interestingly enough, when you for those of you that are from Australia, you'll recall, you'll be aware of the PBS authority system, which is simply a speed bump that's in place when you make a prescription of a drug which has a particular expense profile. You have to make a call to a clerk and read out the text that opens the gate for you to prescribe this drug. This intervention alone has saved billions of dollars, because it has profoundly, introducing that little speed bump has changed prescribing behaviour. And again, from a purely rational and scientific basis, you would, may be very surprised by that. That segues into seeing my practice compared to my peers will make no difference, because my own practice is sound. Well, again, in fact, we know that is one of the best ways to intervene and change behaviour. So, for example, many of you will have experienced the best way to get to open the minds to change for practitioners is often not the New England Journal of Medicine article. It is their own practice, behaviour, and processes that as compared with their peers. Now, one of the other components of this behavioural change is very much that this works best when this sort of intervention is led by a professional peer, and I'll explain that further in a moment. So here's some of the evidence which dispels some of the myths, which many of us, I think, holds true to what it means to be a scientist and a professional. So let's have a look at the theoretical basis for this. And as Tim said before we started today, we were talking about one of the problems is that we tend to approach these problems from the basis of biomedical science, which is a sort of very sort of reductive science, if you like, rather than social and population behaviour change and social science theoretical bases, which is actually much more appropriate for considering this. Now, this is a theory which was the basis for research that I undertook. And I'm just going to run you through this. It might look complicated, but you'll understand what it means in a moment. Now, this profoundly changed the way I and my team started to design our interventions. This would be a routine way that behaviour change interventions such as road safety, safe sex campaigns, etc., would be used. But we don't design things this way. So when we introduced the surgical safety checklist, which you would note has pretty good evidence for morbidity and mortality reductions, pretty significant reductions. This is a way that you can assess how the target audience are going to behave. So let's just go through this now. So this theory is such that the behaviour is informed by behavioural intention, and that behavioural intention is formed by these attributes on the left. So let's just work through them. So in relation to the surgical safety checklist, let's just see this through the eyes of a surgeon. And the first item on here is their behavioural belief. What is their belief towards this behaviour? Now, my experience, we rarely measure this when we set out to do to make a change, but my experience from the field around this was the belief of most surgeons around this was just a lot of rubbish from bureaucrats. And when challenged that this was endorsed by the college, the response from that was still a belief that, well, quote, the college are just a bunch of folks in Melbourne who aren't busy enough in private practice, so that this belief system about we don't believe that this is necessary or useful. Perhaps one of the things we explore the least in this area is the evaluations of the behavioural outcomes. Now that's a function of what's in it for me. So if you think about the surgical safety checklist, what's in it for them? Well, probably additional time to be wasted, and in their experience, very little benefit. They are happy with the way they practice now and their outcomes now. Associated with that is the consequences for non-compliance. And again, in my system, when one asks the question, what happens to a surgeon who says, I have no intention of implementing that practice in my theatre, the answer in most cases is absolutely nothing. So if there's not a lot in it for them through their eyes, and there's zero consequence for them not doing it, then basically you're scoring a big fat zero in this area, which is a make or break for many of our interventions. If we quickly run through the others, this subjective norms area is very important, and again we sometimes fail to address this. So in this area is what do my peers expect me to do? So what do my surgical colleagues expect of me? Well, again, I've already said the college supported this, but there's a lot of onion skinning in cultural terms, and basically this is what, if I'm an orthopaedic surgeon, what do my orthopaedic surgical college mates expect me to do here? And largely the answer to this is they as a group, they tend to reject these changes. The second component of that is, do I care what they think? So for example, we often set up nursing project offices to try and change doctors. So if you look at it here, what are the peers, what are the nursing peers expect me to do? Well, they expect me to do it. But do I care what they think? We've got some good evidence that doctors actually don't profess to care too much what their nursing colleagues think. If we go down to this third section, again, probably more applicable in some other behavioural domains, but control beliefs, will my actions make a difference to patient safety? I've already established the fact that they rarely believe that. If they did believe it, they'd be doing it. Do they have the power to do it? Absolutely, and more importantly, they have the power not to do it without a consequence. So I've rushed through that, but hopefully that makes some sense to you. my own research around this, looking at particular safety behaviours such as incident reporting, intervening when a colleague's about to make a mistake, speaking up for safety when there are concerns, what I found was there are only two things that really, in my study, influenced the behaviour, the safety behaviours, this target behaviours here, for all practitioners. And when you look at doctors, it's even a stronger relationship. And those are two things. The first thing is professional peer modelling. Do I see my colleagues and my boss behaving this way? Not the nurse, not the allied health practitioner, not the manager. Do I see the people who influence me behaving this way? And the second thing is, do I actually believe, not think, not rationalize, but do I believe that this is going to make a difference to my patients? So what does all this mean? What does all this mean? And particularly, what do we do? How do we design and implement successful behaviour change, practice change programs when our target audience neither sees this being modelled in the workplace or believes in the need for and the efficacy of such a change? So we're going to go to questions now, but just before I do, let me run down some of the take-home points in here and cover that last couple of questions. The first thing is, I think, we rarely use a theory-driven approach when we approach change. We tend to say, put a project officer on, design a training and education program, and we're very surprised when it doesn't lead to the change. So we've actually got to use the theory, a theoretical approach to design our interventions. We've got it now. If we do that, one of the first things we have to do is find out what the beliefs are about the current problem and solution. And again, we rarely do that. We do not utilize the science of core beliefs and understanding what people actually believe out there now. One of the critical things here is we've got to find the hook for the what's in it for me, and that often links to what the beliefs are. If we know what the beliefs are about the problem, and in fact, indeed, whether it is a problem or not for the person, we can start to explore what some of their barriers are. And if we can build that in, we're more likely to be successful. We must have this delivered and driven through professional peers. We cannot have a project manager, particularly one from a different profession, sort of leading this change and expect it to work. Where our target audience neither believe in it nor see it modelled, they have to be moved to a position of discomfort with the current status quo. And the best way to do that is by shining the light on their current practice and outcomes compared to their peers. And I think many of you already utilize that tactic. The evidence also supports that we must charge this. We must prime the system first. And so the public health campaign equivalent is really important. Again, targeting some of these beliefs about that they hold about the behaviour. And we've got to align incentives and consequences and be very clear about that up front. If there is no consequence for not taking action on behalf of the practitioner, it is very unlikely in many of the changes that we'll be undertaking that we will achieve the critical mass. We'll get the early adopters, but we will not get to that tipping point. So, Tim, I'll stop there and I'll hand back over to you.
That was excellent. But I encourage the participants we have online to post questions. James, maybe we can just go and leave the last slide up as well. So I think that summary, some of the summary points are excellent. So, John, I think what you said there resonates enormously with my experience as well. And I guess what I'm finding in the cancer translation research sector is I think we need to start bridging these kind of worlds of change management, quality improvement, and then the kind of science of implementation together. Because I feel they're kind of working in silos somewhat. So we're not bringing those together. But your last slide there, those points, I think very nicely show that really, you know, you've got to create almost like cottage burning a bridge for change. You've got to get people to look at what each other are doing, but then you've got to make that part of governance structure as well. So a lot of that is on the service delivery side. But then we also, and quality improvement, then we also need to bring in implementation scientists and others to find what methods work well. But you can't do that without understanding the context and the drivers for peers and so on. So that they need to be integrated. And I don't know whether you comment whether you see that happening enough in the areas you've worked in before.
Tim, I think that I think that hits the nail on the head, and I think that despite many years of investing billions of dollars in safety and quality, quote unquote, around the world, I think we're only just starting to see this come through in the literature, and the way, in my opinion, the way we need to do this now is to really bring together the business of healthcare, so the people that actually deliver healthcare, the sort of clinical and basic medical science researchers, and the, if you like, the implementation science side of that now, which is psychology and social science expertise. And I think the first step really to follow on from, if you like, envelop that, what I've just been presenting, is that we will not solve this problem by merely by sort of the evidence and rational means. I think we have to get people in a room of those ills. We have to lay this out on the table. We have to explore their beliefs about the whole spectrum from you know, lab through clinical research through implementation, and we have to start to build in the right sort of levers in the system to force and drive the sort of investments that we currently make into this new area. I'll give you an example of what the current beliefs are in driving a research strategy in my own organisation now. I'm facing beliefs which are articulated as follows. Current clinical researchers, this is not even laboratory, clinical researchers are saying basically that I am stealing money from researchers to direct research money towards implementation science. That's the strength of belief about this. So, you know, I think this is a much bigger problem than just how we design our interventions. This requires, in my opinion, a radical change to the way we fund, reward, structure, research, as well as connect up the operation of healthcare. So the academic health centre sort of model, I think, is certainly one of the ways to go in that, to bring all those people together.
Thanks, John. I couldn't agree more. We've got some questions coming through. There's a couple of questions here really around, do we have evidence of what consequences are more effective for driving change? And then there's another question around what can we use from pharma campaigns and other of those kind of behavioural type systems. I think you addressed some of that, but I think it's worth chatting about that again. It's interesting that both of those questions again come from methods that we don't necessarily apply from the biomedical research kind of toolkit as well.
Yeah, I think, I mean, that's obviously a very good question. It's one thing saying we need consequences, but which ones work? There was a paper a couple of years ago by Pronovost who started to explore this issue, and the lever that he was using here was credentials. And so, for example, he was starting to propose removal of scope of practice for a couple of weeks based on sort of hand hygiene misdemeanors or recalcitrant hand hygiene behaviour, for example. I think that the true answer is on the negative consequence side at the moment, we don't really know. I think that we need to do more work in understanding that. on the positives, on the sort of the carrot side, we certainly know a lot more about, for example, the use of financial incentives in terms of how you structure the system and how they apply to individuals. Again, I'd have to say that these are pretty broad. These are sort of sledgehammer consequences. I think we need to open this up much more broadly, and the sort of regulation hard end of it is one thing, but right down into the way we, into the social fabric of our organisations. Just what does management mean for a doctor, and how do we shape that in terms of carrots and sticks to be able to start to drive those behaviours? I think we need to know a lot more about it. We need to start investing in understanding that.
Great, thanks, John. I got a message here again. It's actually from Cliff. I think the evidence between the FLAGS program indicates that 65% of NUMs, heads of departments, believe that clinical champions are very important to the success of the program, and 85% believe that management champions are very important as well. Do you have any comments on that? Yeah, I think that's pretty well established in the literature. If you go to the hand hygiene, which is probably one of the best studied behavioural interventions, that you will find pretty strong evidence that, again, as I said before, education alone is useless to change that behaviour. A campaign to change that behaviour absolutely includes and is successful as a result of that professional peer drive. So it has to be led by an influencing professional peer. So doctors need to change doctors, for example, and the presence, the active involvement of an executive has again another quantifiable positive effect. So I think that data that Cliff's quoting is absolutely consistent with other evidence. Yeah. Right, thanks. Look, I guess another point, we're getting close to the end now, we'll have to just run over, which we started slightly late. I think one of the key issues that people aren't locking onto enough at the moment, perhaps, is the fact that I see one of the big game changers in this is data and the kind of access to data we're starting to have. I think it was the CEO of IBM, Ginny Rometty, called it the data is the new natural resource, which I kind of rather like to be mined. And I think, so we're starting a number of programs at the University of Sydney, kind of looking at how we can use that data for good rather than evil, I guess, in terms of assisting in professional development and not just using it as a stick. But obviously in your role as Executive Director of Medical Services, I guess you're starting to get access to that data, and that's obviously so important for here. But I think I see in the next 5 years we're going to have this kind of avalanche of data, and we really need to work about how we actually use that effectively.
Yeah, I think so, and I always get a little bit concerned with just leaving it at that, if you like. Data is going to solve all our problems. I think there's a few qualifiers that, again, I know you would agree with, Tim, and others on the line, which is my data, not someone else's data, which is provided in a timely way with an interface that kind of makes sense, so that it's information rather than just data. And it is used, if you look at the theoretical basis for this, it needs to be comparative data with people whose practice you care about. And if you can achieve those things, and about things that you value, and if you can achieve most of those things, and just literally throw the data on the table, and really the add-in at the end is that you make it public, because we know that changes, that has an additional impact on doctors, then you may not actually have to do anything more than that. So I think one of the closing messages is that, one of the mistakes we make in this is that we choose very high effort, low impact methods to change behavior. we can actually deploy much lower effort, higher impact methods and achieve a much more change. So, I think that's something that I'd just like for us all to keep reflecting on and exploring. When you want to change something, the first step is going to your target audience and understanding what their beliefs are. And how often do we do that?
Okay, well, look, we've had some other questions come through, but I think that's a really nice point to end that on. So, John, I thank you very much for your participation, and I hope that we can continue to discuss. Maybe we can have a kind of wherever we want to conversation in 12 months' time or something to follow up on that. So, thanks very much for participating, and look, thanks very much for listening online. And we will be back to you regarding upcoming webinars that may be covering a similar area.